How to do cataract surgery in a patient with a small pupil. Hi, Mohammed Al-Mala here with another small pupil case. It seems there's an epidemic of patients who have small pupils. With all the medications for BPH or benign prostatic hypertrophy, we're seeing more and more patients who do not dilate well for cataract surgery. And I do a lot of cataract surgery in patients with small pupils. This patient actually happens to also be monocular. He only has one eye, and this is his only seeing eye. So really important that we do a good job here. And obviously, I'm not going to do anything in this patient with one eye that I'm not very confident in doing. So I do a lot of patients, a lot of eyes with small pupils, and this is the technique that I prefer to use. We've already started the capsulorhexis. We raised the anterior capsular flap with one continuous motion with the cystitome. You can rewind and watch that again. And you can see as I'm doing my capsulorhexis here, I'm staying very close to the iris margin. I'm not afraid to go underneath the iris margin here. I've done thousands of cases, and I don't think it's really unusual to get anterior capsular runoff when you go underneath the iris margin. I'm going to attempt to do a cortical cleaving hydrodissection here. I'm going underneath the anterior capsular leaflet. I get one nice fluid wave. Not unusual to get iris prolapse here, so we've got to watch for that when we're doing the hydrodissection in a patient with a small pupil. I'm going in with my phaco probe. We're going to do our Phaco Chop technique. We've got things nice and centered well. This is a Nagahara chopper. Impale the nucleus centrally. And then we go around the equator and we chop. I'm not sure I'm really happy with that crack. Nonetheless, the lens does rotate. So if we're not happy with our first crack, we work out of here. It looks like it's decent. We really got to do a good job with splitting this heminucleus into two quadrants. Okay there. Yeah, I think that's a pretty good crack right there. But once again, not stellar. So we'll rotate here again. We've got a good rotation. And we'll go into our second heminucleus and attempt to crack that into two. Also, that's a good crack. I like that. So now we can start removing these quadrants, and we'll see how things go here. So first quadrant, I use my second instrument to help bring that quadrant into the anterior chamber. You can see that pupil is small, probably getting a little bit smaller, but not too bad. We can still see what we're doing here centrally. The nice thing about doing this horizontal chop is you can really do it with a small pupil. You don't have to groove. And oftentimes when you have to groove, you're trying to get further out. And so when you have when you do a Phaco Chop maneuver, you don't need the pupil to be quite as big. So pupil now is between 4 and 5 millimeters. Not bad. We've got two quadrants out, two quadrants remaining. We're going to rotate that heminucleus so it's easier for us to grab the smaller quadrant with the phaco. And that comes out really nice and readily. One quadrant left, rather large. I like to leave the largest quadrant for last. That way we have the most room to tumble. And we're going to take our time here. We want to make sure we protect the posterior capsule in this one-eyed patient. Second instrument there behind the lens, protecting the posterior capsule. We'll take our time here with the phaco. This is a torsional phaco and has intelligent phaco, so as we get closer to occlusion, it does give us some longitudinal as well. Very nice, making good progress here. And one last piece remaining. We've got a few fragments here. We want to make sure we get all of those out. And that looks really very, very nice. We're going to polish the posterior capsule now. So we'll go in with a Terry Squeegee, and we'll use that to polish any cortical fragments or cortical strands off the posterior capsule. Often, I mean, with the microscope view, I have a better view, so I can see those fragments, I can see those cortical remnants better than what we can see here with the view through the microscope, I mean, through this camera, through this recording. And then once I'm happy with that, I'll inject viscoelastic. I'll go into the anterior chamber angle, both to the left and to the right of the wound. And we want to make sure we're not leaving any nuclear fragments behind. We fill the posterior, we fill the capsule with viscoelastic, and we're using ProVisc here. And now we're going to inject the intraocular lens. This patient had a very nice outcome. We use our IA handpiece to position the IOL. I irrigate out to remove any air bubbles, but when I go into the anterior chamber, we are going in dry. No irrigation yet. Now we're irrigating. Once I don't start irrigating until the IOL starts to unfold, and I'm sure that the haptics are not stuck. So we'll do viscoelastic mode first, which starts out with pretty high vacuum and aspiration, and then we'll go into a cortex removal mode, which has more control over the aspiration as well as vacuum, and that's what we use to go behind the intraocular lens. Good. I'm going to use here, this instrument is called a Sharvelle, and we use it just to retract the iris, look for any remaining cortical material that may be there, and we do see some cortical material there, and we're going to use the IA to remove that. You don't have to be super aggressive with this. There's really not much cortex remaining, but nonetheless, if I see it there, I'll go for it anyway. Please don't feel like you have to do this part here. It's good to take a peek and make sure you're not leaving anything large behind. I use a corner wand to retract the iris here as well. And it looks like I do see a little bit of cortex there. In any case, like I said, we don't have to be too aggressive with these really fine cortical strands. Patient safety number one. So now we are essentially done. We want to irrigate the wounds, make sure the wounds are watertight. The order of irrigation, I start out at the main wound first. I just hydrate the lips of the wound. I'm going in just to make sure that there's no pieces here in the anterior chamber angle. I hydrate the lip. I'm not really filling the anterior chamber. Now I fill the anterior chamber with BSS. I push down on the IOL. I can't see the capsular edge, so I want to push down, make sure that there's no, that the IOL optic is completely in the capsular bag and none of it is in the sulcus, and that's why I do that maneuver where I push down there. There's some reverse pupillary block there. When I try and inflate the anterior chamber, the pupil gets really big, so I just reached in underneath the pupillary margin with the cannula there to separate that out, and that breaks that cycle, makes the pupil come down again. Very good. I'm very happy with that. We're going to check the wounds. I'm happy with the intraocular pressure, make sure there's no leaks, and that is it. So that's how I do cataract surgery with a small pupil. Very important you do whatever technique gives you the safest outcome in your hands. And this is what works for me. Thank you for your attention. I hope you learned something. Always feel free to comment with any questions and your thoughts on this procedure. I hope you learned something. Thank you.